Hi, my name is Ricardo Parker. I'm an associate professor in the Department of Health Sciences, School of Health and Human Services at National University. I've been at National for 5 years. I am academic director of the Allied Health Program, working not only with students, with faculty and other staff to work with what we call adult learners in teaching, promoting, educating, not just the academic side of it, but how do we turn it into practice. I started with my PhD when I did my postdoc at the National Cancer Institute as a clinical cancer research scientist. I got that training working in drug resistance with ovarian cancer patients' tumors and doing studies on their tumors to look at certain mechanisms that patients are resistant to certain types of drug treatments, and working with patients' material, in this case working with their tumors or their blood. We were able to predict how they may respond to certain treatments before they actually get it, working with the tissue. That experience at the National Cancer Institute as a federal organization, after I finished my postdoc, I had the opportunity to go into biotech. And with biotech, this particular company was taking patients' tumors, and we had the ability to create a profile, a drug response profile, and we're able to identify patients' tumors that were resistant to chemotherapy. The doctors gave us their viable tumors, and we tested the tumors against various drugs that the doctor was trying to decide which one to best use for his patient. We had a test that was 99.8% accurate at identifying what we call extreme drug resistance. And if with whatever panel of drugs he or she was deciding to use, we could identify the ones to eliminate from that decision, and with that information give the drugs that will have best response for the patient. We also, in that capacity, I also developed a few tests that were predictive and prognostic tests for predicting extreme drug resistance in patients. We developed clinical trials, work with a lot of clinicians, various states, practically almost every doctors from practically every state in the United States are sending us their tumors and testing. From that life, I went into academia started off on the administrative side as a director of pediatric research and pediatric division at Loma. Had a very interesting experience with managing clinical trials, cancer research, and just trials in general, mostly with the pediatric population. From that experience, then moved into the other side of the fence. Administration in academia is one thing, but now to work on the faculty side and working with students in training and teaching is a whole new aspect and a beautiful aspect. So when you ask me the question about what side do I want to talk about, I have gone almost full circle into what's called governmental research, into the administrative components, or biotech administrative components, and now in the faculty training and teaching students. All of those I think have kind of gave me opportunity to enjoy what I do, to be passionate about working with people, talking with people, gifting information, just to get more people, more young adults, folk engaged in whatever career tracks they're on, and perhaps enhancing that by giving them some stimulation, motivation to continue with what they do. I think it's important when you consider, when people talk about research, a lot of folks might be starting to look at the lab bench. My experience was in the transition, what we call a translational part of research, where we're actually taking the information that we've learned at the bench and moving them into patients with clinical trials. The beauty of it now is that with this information that we learn in that educational process, that learning process, you can glean very important information that can be applicable directly to treating patients. That is when you look at the academic side of it, that's my scientific mind thinking. But what really, when the rubber meets the road, is what we bring to our individual patients. While we provide tools to help improve their biomedical state, their medical state, it's the mind, body, spirit, I think, that connects us as people. But really is at my core is when I interact with patients, when I interact with individuals that are either dealing with cancer, the experiencing the disappointment that when they were diagnosed, the fear when they were diagnosed, and the apprehension, now what do I do? As that compassionate part of me reaches out to them, I understand the human side of suffering. A number of my friends and best friends developed cancer. And when they were going through the radiation, the chemo, I was there coaching. I was part of that, helping them get through that process. And then when it reached the point where there was nothing else available, that's when really the connectedness comes into being, that to speak to them about our friendship, our spiritual connection, to prepare them for being at ease with what we've done, what we could. We have this friendship, this connectedness that will transcend all of us. And I want them to know that as a friend, as a partner, as another human being, that I reach out to them. I have that sensitivity that I want them to appreciate that there's someone like myself who is there to work with them, to be with them all the way to the end. And I've had the experience of being with friends when they're on the deathbed, dying, being a part of that transitional process. And it reminds me of my own humanity. I direct the Allied Health Program, and I see the healthcare system, one as having an infrastructure that allows us to work directly with patients, to work with their families. That is structural application part. I'm also one that will volunteer and go and speak to community organizations, grassroots organizations, churches, to speak about cancer, about the importance of clinical trials, why we should be engaged in clinical trials, about health and nutrition. I go out and talk about the link between disease and nutrition, cancer and nutrition, those that are survivors, how best to manage their lives. Let the doctors take care of the disease, you take care of the rest of you. And give some suggestions on how to keep yourself healthy, mind, body, spirit, how to it's the importance of having a family around, the importance of having friends. A lot of cancer patients, they get to the point, especially when they're in the middle of their treatment, they feel so miserable that they just don't want to be bothered. That is when the family should be closest. And closest doesn't necessarily have to be in their face, but to be there for a touch. A human touch is a healing thing by itself. To be there, to be a friend. I believe to share the information in open public environment, and as a professor in the classroom, let students know that while it's all academics, how do we apply that to who we are, who we become? If we're going to be the future professionals, healthcare professionals, how do you perceive that on the human level? Not necessarily, well, you have a degree in such and such, and this is what your job is going to be. How do you make that more personable? How do you use that to better someone else? The most important thing to ask a person, how can I help you? What can I do for you today? That opens up a whole new range of conversations. It's not just checking off a box. It's about engaging people. I've had the opportunity to speak to grassroots leaders, to go to churches and speak to some of the committee members or church members if they have a health ministry. Go to high schools. I've done that as well. Speaking to students about whether they're interested in going to the healthcare field. As a cancer research scientist, biomedical research is expanding exponentially, and the opportunities for different ethnicities, particularly those of us that are in underserved communities, stimulate an interest, stimulate an excitement about going to college, to grad school, to med school, to build on something a passion that they can now use as a tool to give back to their community, to give to a broader community. My whole point about really trying to get to where people are, meeting them where they are, is to take what I understand, what I know and appreciate about disease, cancer, disease, nutrition and disease, and talk about what types of things in the diet that we should enhance, types of other things in the diet that may exacerbate or aggravate a condition. For example, if it's cancer, you're undergoing chemotherapy, it's important to eat a lot of fruits, vegetables, and maintain nutrition. If you're undergoing, if you live in an environment where there's not a lot of fruits and veggies. For example, a lot of food deserts are around. To be able to speak to folk about what are we doing right now to make some small modifications to improve our condition, our personal condition, our family's condition, our community. It's low-hanging fruit that's available and out here that you can bring to the attention of individuals. Working with the Green Foundation, we've presented several conferences over the years, at least 6 conferences in northern and southern California, to go in as health professionals and speak to smoking cessation, again, cancer, nutrition, disease. How do we work to eliminate, to look at prevention and protecting ourselves and our bodies against disease, how to better improve quality of life, changing behavior. We have a nurse managed program at National University where we're actually in the Watts community. And Watts being an underserved community, historically one time it was predominantly black and now it's predominantly Hispanic, but still the disparities are prevalent and even more challenging. Several things about this concept of disparity is just an inequality of accessibility and accessibility to the quality of healthcare. What I try to emphasize to my students and to others, that it's the inequities that make it more difficult for this access. Somewhere in the body politic, we have to first appreciate this inequity and then look at the resources, look at other tools that are available, and how do we make that a more balanced thing. Accessibility doesn't necessarily have to be this thing about having the money. It's about having the resources available and making those resources more readily available to individuals. We're working on a diabetes program. One of the biggest challenges in an underserved community, particularly one in Watts, is a large percentage of those individuals already have poor health. And there's certain health behaviors that are leading to, let's say a downward spiral. But to be able to turn that around by providing this, what we call telehealth, being able to have in the heart of that Watts community a point of care clinic that they can walk in, get free or medical treatment that for a very low discount price or perhaps even free in some instances. When you look at the traditional model, particularly in an underserved environment, those individuals with diabetes hardly ever go to the hospital, and when they go, they are already perhaps in a crisis situation, and the amount of services that may be available is going to be more strain on resources, and so the cost of that is going to be much greater, as opposed to with telehealth, as now you have the technology you can go in to meet the people where they are. For example, there's diabetes, run a blood glucose test to immediately, with the tools, that information can then be sent directly to someone that's at a computer to access the information, and the doctors can provide a diagnosis or some guidelines immediately, as opposed to an individual having to catch a bus, take the day off, wait, take a blood test, and they take it off to some lab somewhere. The time and all the other expenditures, human as well, associated with that, versus access almost immediately, so they can get rapid turnaround. It saves incredible medical dollars. We put together a protocol. At least we ran a feasibility study, proposed a feasibility study. We did a cost-benefit analysis to show that if we had a telehealth program available actually we do have a telehealth program, but to have that in an underserved community, the costs to run a diabetes monitoring or management, we call point of care service, would be for 200 individuals over a year, about $302,000 for telehealth in that environment. Versus, you can contrast that to the traditional treatment of those people, and you're looking at it would cost about $11 million to manage them in the traditional setting. So when you actually look at a telehealth point of care service versus the traditional, that $302,000 to $11 million, when you look at they call it the cost-benefit ratio. For every dollar spent in this telehealth point of care, you can save $11 million for 200 people over a year, and that's for one site. And now what we're proposing, at least at the nurse managed program, we're proposing 30 sites of that type. So the cost savings can be realized easily. It goes back to making healthcare more accessible. One of the bigger challenges we're having right now is the leadership, and also the funders, the policymakers. It's a political will. We have to have the political will to make some changes. Healthcare as it stands, when you consider the direction we're moving medicine into prevention, we're looking at population health now. So when you consider population health, health of the individual surrounded by the family, wrapped around the community, and then the greater community. That's where the rubber meets the road, and we have to pivot our healthcare system to accommodate that profile, if you will. And I think for Healthy People 2020, now we're moving into Healthy People 2030. Those guidelines, those objectives, and those activities, I think it's what's going to be driving the healthcare system in the future. But right now, the political will is not there yet, but we're getting there. We have to. Fee-for-service is unsustainable, will be unsustainable given the baby boomers are coming through retirement right now, and that's going to create an even greater pressure on the healthcare system, as well as some of the other challenges with having accessibility for healthcare. Medicare, all of the systems are going to be significantly impacted. And we have to change this monkey. We have to literally look to move towards another way of doing what we do better, differently, and on a more equitable level. Doesn't necessarily have to be equal, but equitable. Planetree is a movement. It's a means by which we incorporate our humanity into what we do as a profession. Healthcare is not mechanical. It's not having tools to just work to make people feel better. It's about how we incorporate our humanity into those processes, so to give people hope and they give us a true sense that we are all in this together. As a cancer research scientist, I have significant publications in cancer drug resistance, chemotherapy primarily. I have a lot of publications in that field. My contact information, I'm at National University, email rparker2@nu.edu. I can be reached there, and I'm more than happy to talk to young people, high school, college, and for that matter, grassroots organizations, to come and talk to them about health and nutrition.